The meeting of the board to order. Will the secretary please call the roll?
Director Curry,
Present.
Vice Chair Deere,
Present.
Director Garza,
Present.
Director Guggenheim,
Present.
Director Harrington,
Present.
Director Kim,
I'm here, and I just want to let people know I need to leave at 10 o'clock. Thank you.
thank you, Director Ketting,
Present.
Director Munar,
Present.
Director Prendergast,
Present.
Director Ryder,
Here.
Director Story,
Present.
and Chair Taylor.
Present.
You have a quorum.
Thank you. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. To streamline, we will combine the action items into a combined motion. Meetings of the CCH board and its committees will be held remotely until otherwise noticed due to the determination that a public health emergency exists. The next regular meeting of the board will be held on Friday, August 26th at 9 a.m. The first item on today's agenda is employee recognition, which will be reviewed by Mr. Rocha or his designee. I believe it's Ms. Amos today. Amos
Yes,
today?
it is.
Thank you.
It's Valerie Amos.
Great. Good morning, everyone.
Good morning.
All right. Okay. So we are pleased to share that we have a number of new leaders within the organization. We would like to welcome Pam Esposito as our Senior Behavioral Health Officer, as well as Raji Thomas, who joined us as the Director of Patient Safety, Justine Morden as the Assistant Director of Regulatory Affairs and Accreditation, as our Policy Coordinator. So please join me in welcoming them.
Welcome.
Welcome.
Good to have you.
In addition to that, we have some promotions and interim assignments. We do have some direct appointments. Dr. Arnold Turner as our Chief Hospital Executive of Providence Hospital. Aaron Galiner is our Chief Administrative Officer of Health Plan Services. And Carolina Duzic as the Interim Chief Operating Officer of Health Plan Services.
Congratulations.
Yes, very well done.
Okay. So we will move on to our physicians as well. Dr. Elizabeth Marcus, she has been recognized as Chicago Magazine, within the Chicago Magazine as our top doctor. She's our Chair of Breast Oncology. Please join me in recognizing Dr. Marcus.
Congratulations, Dr. Marcus.
Congrats.
Right. And then in addition to Dr. Marcus, I apologize. Debbie, if you could go back to Dr. Marcus's slide, I do have some more information. Dr. Marcus, she's our chair of breast oncology for Cook County Health. She was named to Chicago's Magazine's top doctor list for 2022. Dr. Marcus is an expert in oncology who specializes in the treatment and prevention of breast cancer. She has expertise in treating locally advanced breast cancer and conducting research to improve multidisciplinary treatment. Dr. Marcus is particularly focused on caring for underserved populations and serves as a subject matter expert on improving care delivery to minority communities as a member of the National Cancer Institute Breast Cancer Steering Committee. So again, please join me in recognizing Dr. Marcus.
Well, congratulations, Dr. Marcus.
All right, the next one. Okay, we have Dr. Mike Alabik. Dr. Mike Alabik is the co-director of medical student programs and attending physician in the Division of Hospital Medicine. He has been named as our emerging leader by the Health and Medicine Policy Research Group called the HMPRG. In his nomination, Dr. Alabik was recognized as a dedicated problem solver. He takes on whatever obstacle may interfere with patients getting what they need and works for solutions with an eye towards access and equity. He is about making things better for everyone. Despite being early in his career, Dr. Alabek's leadership has already made a tremendous impact at Cook County Health. The award will be given at HMPRG's Gala on September 29th, 2022. Please join me in recognizing Dr. Mike Alabek.
Congratulations.
Next slide. Great. Next slide, please. All right. So we have in Becker's Healthcare, recently recognized two Cook County Health leaders. Cook County Health Chief Strategy Officer, Andrea Gibson, was named one of the great chief strategy officers for health systems in the country. Becker's notes that the recognized chief strategy officers drive forward key deals and initiatives aligned with the health system's core mission and growth. They are champions of digital transformation and cultural shifts for the organization to deliver better, more effective patient care. Ling Dang, Chief Experience Officer, was named an outstanding Chief Experience Officer. The best Chief Experience Officers are obsessed with delivering truly patient-centered care and focused on breaking down organizational barriers to a seamless, stress-free patient and caregiver experience. That was written by Becker's. So please join me in recognizing both Andrea Gibson and Ling Dang.
Well done, both of you.
All right, next slide, please. Okay. All right. So the Cook County Juvenile Temporary Detention Center, JTDC, was granted full accreditation status of its healthcare program by the National Commission on Correctional Health Care, NCCHC. The two-day survey reviewed NCCHC standards of compliance over the last 3 years. Cook County Health's CERMAC Health Services provides care for patients at JTDC. Congratulations to the entire CERMAC team for this achievement.
Congratulations, team.
All right. Next slide, please. Stroger Hospital was recently recognized by U.S. News and World Report as a high-performing organization for chronic obstructive pulmonary disease, COPD, and pneumonia, as well as heart attack and heart failure care. U.S. News and World Report annually rates hospitals for their performance in treating more commonly occurring conditions and medical procedures. Among the criteria looked at are patient outcomes and volumes of a procedure done. So high-performing organizations rate significantly better than the average or national average. So again, just join me in welcoming and recognizing everyone and all of our organizational achievements.
We really appreciate it. Congratulations all.
Thank you so much. Debbie, next slide.
I think that's it. Well done, all. A lot of achievements for individuals as well as the organization. I think it speaks to the great work that all are doing to contribute to Cook County Health. The next item is public testimony. Madam Secretary, do we have any written testimony that was submitted to be read into the record?
We did not receive any.
Okay, thank you very much. The next item is the annual meeting business, which includes the election of the chair and vice chair. I'm going to temporarily turn over the chairmanship to Vice Chair Deere during the board's consideration of the item related to the election of the chair, as I will be recusing myself from voting on that matter. Over to you, Vice Chair Deere.
Thank you so much, and good morning to everyone. I'd like to open the floor for nominations for chair of the Cook County Health Board.
Vice Chair Deere, this is Director Garza.
Morning, Director Garza.
Yes, good morning. I would like to nominate Lyndon Taylor for chairman of the Cook County Health Board.
Second.
All right, it has been moved in second for a nomination for Mr. Lyndon Taylor. Are there any other nominations?
Mr. Chairman, Mr. Vice Chairman,
Yes.
I propose that the nominations be closed for the chairmanship of Cook County Health and Hospital System Board.
Thank you so much, Director Story. As there are no other nominations, the floor is now closed. And we'll vote on the matter of election of Mr. Lyndon Taylor as chair. Madam Secretary, will you please take the roll and call the vote?
Roll call on the motion to elect Lyndon Taylor as chair. Aye or nay, Director Curley?
Aye.
Vice Chair Deere?
Aye.
Director Garza?
Aye.
Director Guggenheim?
Aye.
Director Harrington?
Affirmatively, aye.
Thank you. Director Kim?
Aye.
Director Ketting?
Aye.
Director Munar?
Aye.
Director Prendergast?
Aye.
Director Ryder? Director Ryder?
Oh, very enthusiastic and emphatic aye.
Thank you. Director Story?
Aye.
And Chair Taylor?
I
I believe you were going to vote present, Chair Taylor, or no?
vote present. Exactly. Thank you.
Thank you. So you have, Acting Chair Deere, you have 11 yays and 1 present.
Thank you so much. Motion carries. Chairman Taylor, congratulations, and I yield the chairmanship back.
Thank you very much, Vice Chair Deere, and thank you all directors for your support.
Congratulations, Chairman.
Thank you very much.
Good luck.
I appreciate that. I appreciate all the support, and I'm thanking you in advance for all of your help. The next item, I'd like to open the floor for nominations for Vice Chair.
This is Director Harrington. I'd like to nominate Commissioner Dennis Deere.
I like to second that.
Do we have any additional nominations? Thank you. Given that there are no other nominations, the floor is now closed, and we'll vote on the matter of election of Dennis Deere as Vice Chair. Madam Secretary, will you please take the roll call vote?
Roll call vote on the motion to elect Director Dennis Deere as Vice Chair. Aye or nay, Director Curry?
Aye.
Vice Chair Deere?
Present.
Director Garza?
Aye.
Director Guggenheim,
Aye.
Director Harrington.
Enthusiastically, aye.
Thank you. Director Kim,
Aye.
Director Keding,
Aye.
Director Munar,
Aye.
Director Prendergast,
Aye.
Director Ryder.
It's no secret I love Dennis Deere. Aye.
Thank you. Director Story
Aye.
and Chair Taylor.
Very much aye.
So you have 11 yays and 1 present.
Thank you very much. The ayes have it. The motion to elect Dennis Deere as vice chair carries. Congratulations, Vice Chair Deere.
Thank each of you all so much.
That is great. We look forward to working with all of you for the next term. Next on the agenda are the board and committee reports. The minutes for the June 24th board meeting are being presented for your approval. Approval will take place in the combined motion later in the meeting. Are there any corrections or revisions needed to be made to the minutes that you received? Hearing none. Next, Director Prendergast will review the HR committee metrics with Valerie Amos, Chief Human Resources Officer. That committee did not meet this month, so those metrics are being presented directly to the board.
Okay, thank you, Chair Taylor. Good morning, everyone. As mentioned by Chair Taylor, the Human Resources Committee did not meet this month. The next regular meeting is scheduled to be held on Thursday, August 18th at 12 noon. The committee is due to present metrics, and so I will turn the floor over to Ms. Valerie Amos, our Chief Human Resources Officer, to review the metrics today. As a reminder, there is no motion needed. These metrics are being presented for informational purposes only. Ms. Amos, the floor is yours.
Great. Good morning again. This is Valerie Amos, Chief Human Resources Officer. Thank you so much for allowing me to share the metrics report today. In terms of what has transpired since FY22, which is December 1st through the end of June 30th, HR has been working or actively recruiting for 2,100 plus positions. So all of those positions are within human resources. At this moment, we have hired 317 employees. A number of those are internal transfers, and we, of course, love our transfers because we want people to feel like there are promotional opportunities and internal and career development and movement. We will be, again, tracking and trending a much higher rate on our external hires so that we can exceed the number of internal hires and internal movement as we track and trend with our external vendors who are here to support us. In the upcoming slides, I'll share a little bit more detail about that. Next slide, please. Here's our depiction, or a less complicated depiction of the former waterfall slide. The request to hires, or the number of vacancies, again, that are within the Human Resources Department. As I mentioned before, it exceeds 2,000. The positions at this moment, again, from December 1st through June 30th, we have posted almost 1,800 of those. So we still have some more posting to do. The postings that have closed are over 1,500. The postings that have been, or positions that have been validated, which means the recruiters have actually reviewed those candidates that have applied, reviewed those resumes to ensure that they have met the minimum qualifications, and then those that were referred for interviews have been almost 800. The completed interviews are almost 500 by our departmental managers, and then offers are nearly 450. Offers were extended, and of that 450, 317 individuals have actually started their positions with us. So whether it was internal or external, they have physically started their positions with us. Mr. Harrington?
Yes. Do you have an idea of what the percentage, the 2110, is percentage of our total workforce?
Actually, I do. In the upcoming slides, we can talk about that, if that's
Thank you.
okay with you. Okay,
Thank you.
great. All right, perfect. Next slide, please. Here's our separations. We have a number of resignations this particular during this particular time frame. Of course, resignations out of the 3 buckets below, retirements and discharges. Resignations continue to lead the way. So we definitely need to focus on our retention strategies. And I know as a senior executive team under Mr. Rocha, we have really been discussing strategies there, and we'd like to come out with a very strong plan so that we can ensure that we are successful with retaining our staff. So this particular quarter, as you can see depicted, we have lost 149 individuals, and it's pretty much in par with the past 2 years. Next slide, please. So, Mr. Harrington, I think that this pretty much addresses one of your questions, or the question that you presented. At this moment, the number of employees that we currently have on our books is a little over 5,400, Q3. And again, the separations were 149. So of the total workforce, again, we would certainly like to see that percentage added to the number of employees so that we can have the full workforce. So I don't have the full budgeted number. I think it's closer to probably 6,000 or 7,000 in the budget book, but and that includes all of our grants and all of our other positions that are not necessarily fully funded for all of the future years, but the grant funded positions and many more. And I know our finance team can certainly give you the exact number. I know that we do have about 35% vacancy at this moment. Does that help you?
Yes, it does.
Okay. So I think that this slide is also critical for you to see the progression of how turnover has really impacted CCH. And I'm certain that this is happening probably across the country as well. As you can see in FY20, we had, if you look back at Q1 through Q4, we were well above 6,000 employees. And then it progressively declined in 21. And so we're still seeing that number decline. So we'd like to really, again, plug the hole and ensure that we can retain our employees as we continue to recruit. Other questions? Okay, we'll move to the next slide. So how are we progressing? I know you've seen this slide before. This is kind of this is the core. You'll probably see it in every board meeting, because I want us to just stay focused so that we can continue to track and trend on these 4 imperatives. Next slide, please. So here's a depiction of some of our changes. Now, I showed you metrics before. Those metrics were people who had actually started within CCH. As you know, you have heard me talk about our external vendors. Slalom is one of our vendors, and Cross Country, the RPO team, is the second vendor. So let's see the progress of what has been occurring. Slalom and with the support of our internal IT team, our HIS team, and our business intelligence team, we've all come together. We've developed this metrics dashboard. This metrics dashboard is powered by Tableau, and it's something similar that the county has in place as well, as I understand. So this is really a summary or depiction of our stats from the dashboard. So to your left, up top, we started tracking from May 16th, when we were able to start pulling all of our manual data together, tracking and trending. So we've been tracking since May 16th through July the 22nd. 220 candidates have accepted our offers since that time. 94 of those were internal, and 126 have been external offers that have been accepted. So why is that number different from that first slide that I mentioned? This is real-time data that we are tracking and trending so that we can start producing more real-life data for our hiring managers so they have visibility into this metrics dashboard. The dashboard was rolled out to about 65% of our management team members. So it represents over 1,400 of those 2,100 positions that you saw earlier that we are actively working on. So they can receive a status update of what's happening within recruiting immediately. And again, what we've been noticing is that, the tracking ability from our decision to hires, or when those managers are sharing their offer requests to us, we've been tracking that particular metrics. And I know that there's a lot of metrics that we can track, but that's the one we are focused on at this point. And I can share with you, tracking this, so pre-May 16th, the average of days that it took our team from an offer request by the department to when a candidate actually accepted our offer was about 36.8 days. So right at 37 days, that's more than a month. So we've lost the candidate at that point. That was one of the biggest frustrations that I heard from a lot of management team members here. So we wanted to track it and address it as best as we could. Now, post May 16th, we have dropped that by almost 10 days. Now, we still have a long ways to go, but we are looking at tracking and trending the time that an offer gets to us by the time that we can definitely extend it. So our goal is to push that down to actually 3 days. So as we've been tracking towards getting the offers out in 3 days, but looking across this entire fiscal year with all of the delays that we had, to average it out, we've only probably moved the needle about 10 days. Director Prendergast.
Yes, a quick question. It actually is referring to something on a previous slide. I see on this slide where you have the reasons. Are we doing exit interviews for the resignations, and I know that that's not always possible to get that, but about what percentage of those resignations are we getting able to do exit interviews, and do we have is there anything that we can say about the reasons, right? I think in terms of trying to troubleshoot and that might be some helpful information. I see that you're tracking it for the reasons for decline. So I was just wondering if we're doing something similar for the resignations.
Yes, we have an exit survey, and honestly, the percentage is very low. And I can get the exact stats for you. I know I presented some information several months ago regarding that, and we were in the process of actually modifying it so that it's more, it really gets to the core of things. It was very generic. So what we were seeing at that point in time, people were leaving because of, better opportunities and so forth. So I'd like to maybe come back with some more concrete information about it, because we need to really upgrade and update that. So a member of my team has been working on updating it, because what we have today is not as comfortable, in my humble opinion, as I like to share. We do have some data though, and I'm happy to share it.
Okay, thank you.
I see another hand. Okay. Director Curry.
Yes, Director Curry, thank you. 2 questions.
Sure.
The first is regarding the upper right-hand corner on tracking your goal.
Yeah, I was about to get to that.
Okay, I'll
All right.
get first until you get to actually both of them. Okay, I'm ahead.
I was about to get to it. Not a problem.
No problem.
All right. There's a lot of information on this slide, so it's good stuff. Our goal, we set a goal for ourselves for 400 external hires under the direction of our CEO, of course. So we have an aggressive big audacious goal here. By September 1, our goal is to hire 400 people. As of last Friday, 126 offers were accepted, and they were all external. So that is why that tracking tool is in the upper right-hand corner. Of those individuals, that 220, 154 of those have started since May 16th. So that's the number to the right. And if you look down below to the lower left, 120 more candidates, those offers are coming to us in the pipelines. We know that those individuals are being selected and coming towards our team so that we can review all of their information, ensure that they meet the minimum qualifications, and extend those offers. And we have a team approach with that as well. To your point, Dr. Prendergast, we are tracking now the declinations, and that's something we hadn't been doing before. So we wanted to expand our tracking ability and have some benchmark data that was not in place before. It was in the body of emails, phone calls. And so we want something concrete, and we just started tracking that since April. So I know this is probably a little, different from what you've seen, but I want to start transitioning to more talent analytics versus, just all of the mainstream information. Okay. Dr. Harrington?
While we're talking about tracking, and I appreciate the goal of 400, but as we continue to have resignations, we may never get back to where we were. And it may not be a question to answer now, but I'm wondering what impact that has on our ability to provide services, because we don't know what positions these are. And so, and what would be the ideal workforce in terms of numbers and positions for us to have? That would be something that would be helpful to know moving forward if it was somehow getting closer to what the ideal would be. And that may have been covered in a previous slide, but it'd be helpful to know if it appears that we're making progress, but there may be some way to demonstrate we are making progress, and you are getting to a point where we feel confident that there will be no reduction in service of care as a result of resignations and terminations and things of that matter.
Absolutely. I know that we are definitely focused on providing safe, quality care and service. And that's why we've come before you so many times to talk about our supplemental plans while we attempt to rebuild. And I know that you'll probably hear more reports about our quality and safety and service, and I will defer to my colleagues on those things. But it's a very good question, and we certainly want to backfill with permanent positions. Our goal is not to continue with additional support staff, and so I think we're all driving towards the same goal, and I appreciate that.
And Valerie, if you give me one quick second, this is Israel.
Sure.
Sure, Doctor, I want to make sure we respond to the question. We actually have made sure that there is always some things we cannot make up with interim staffing or others, but given that we have had higher, we actually, if you look at our metrics, have had almost 20% more inpatient admissions than we had expected. We not only have been able to maintain, but increase services. Now we've had to have agency staff. We've had to be able to do that on patient line care services. We always focus on making sure that we have what we need and making sure that it's done safely. From a frontline care perspective, there are some things that are harder to replace, such as physician recruitments, nurses who have been with us for many years. That type of institutional knowledge is harder, but we do make sure that we maintain services to be able to keep going forward. And so while we have the vacancies, I want to make sure it's very clear that the money is not completely sitting vacant. You have heard, that we've had to do transfers. We are hiring staff. There are people in those positions. They're just temporary, and we're trying to convert them to permanent. But we take our ability to maintain our care very seriously. And so we will be happy to give you periodic updates on what we're doing and where we're having issues. Some of our biggest impact has been on outpatient services on the primary care side. That's a little harder because that's long-term patient empanelment. But we do our very best to make sure that we are continuing to render the critical services that our system and community needs while mitigating the efforts of the pandemic. and also having the issues that we're seeing across the country from the workforce shortage. And so despite those issues, we have been able to maintain the critical care services that we need. There is much more to be done. And so we are working as quickly as possible. This set of metrics and the goal is to increase the speed. This is nowhere near the end where we want to be, but our goal is to be able to replace our full complement of staffing and to get faster. So these metrics, we believe, are what will give us insight into what we can do to continually get faster to onboarding. We would like to be able to turn a position around as quickly as possible and get offers, as Valerie said, within 3 days. And from posting a position to getting candidates in the position, try to make that as short as possible in under a month's time, which is a very big change from where we were at. But I think it will show us how quickly we can get there, and we will continue to move forward and give you updates. But we work very carefully, and we can have our nursing leaders and our clinical leaders give some additional updates in upcoming meetings, as they have in the past, to show you how we're able to meet our care needs.
Thank you.
Hi, this is Director Curtin saying myself. My 2 questions then. Back to the tracking our gold and all the efforts that are made. It looks like things are good. On the right side where it's reading, we are tracking towards hiring 400. I know there's a 400 goal. So based on the results you have through the 22nd and then another week or so with that, does it appear, or how confident are you that we'll hit that 400, or is that still just we're tracking towards, or are we confident that we will on September 1st hit that 400 external goal?
So we are planning, and well, we have finalized a few of these. We have 6 events already planned, and we are in the final stages of those 6, so that we can really bring in some robust numbers. So we're going to talk about some of that and how we expect to achieve that goal by September 1. It is aggressive. It really is aggressive, and it's market driven, and it's all about the candidates and how we attract them to the organization. I wish I could answer that with certainty, but our goal is on track to host events so that we can get to that number. And I'll share a little bit more about our virtual events. We have 6 of them planned for August. And it's all market driven at this point, and our ability to attract them.
So you'd like me to ask me to be patient until September 1st? And
I would like all of the board members and everyone who's listening to tell people to attend our virtual job fairs and interviewing blitzes when I talk about it in the next upcoming slides. That's our public service plug.
All right. In the lower right corner on the reasons for the declinations, I noticed that 11 or 1/3 of the decline reasons have to do with pay below market rate. And is there in that group, is there any particular tranche that reflects that? I think I know, but I'd like you to share, if you do know, which job classifications seem to fall most often in that category.
Those were primarily clinical positions.
Okay.
And
I assumed that, but I didn't want to assume. Okay.
Absolutely. And we know we're in the Illinois Medical District, and so we have some steep competition with some other organizations who are just as competitive as they want to be. So we just need to really drive towards change there, and we have been working towards recruitment and retention proposals as well. So we are attempting to be more contemporary with not only our approach to how we are recruiting, streamlining some of our processes, as Mr. Rocha mentioned, in terms of speed, velocity, and just throughput with recruiting. It takes such a long time at times to get things done, and we want to streamline that as much as possible so that we can do our best for our patients and our employees. We want our employees to feel confident that they have more new employees coming, and they are excited about staying at our organization.
Thank you.
No problem. Director Ketting?
Yes, I don't fully understand the number in the lower left, the 120 candidates awaiting offer.
Sure.
Once we have a candidate and we decide that they are appropriate to get an offer, what takes so long?
So again, those candidates, their information has to, one, be validated by teams, as well as ensuring that they're necessarily, their credentials and all of that is in tow as well. And then we have some paperwork on our side too, to ensure that we have completed everything in order to properly extend those offers. So what we tend to do is verbally extend those offers, and then we finalize all of our documents on the back end before they move up to that top column, that 220 column.
Okay. Okay.
All right. Next slide, please. So as I mentioned before, we have external companies that have been helping us, and thank you for your support with allowing them to continue to work with us. We have been working with them to stand up hiring meetings. Our target is 72 hours to extend these offers. We are, again, over the past, fiscal year at this point, we haven't, of course, hit 72 hours because we just started tracking this May 16th. But we are tracking towards our goal of external offers of 400. Incredible Health is this company that provides nursing staff to us, and we have been working with them since June, and they have been sourcing candidates for us. So they are a sourcing company. They drive people to our organization, and so far we have been looking towards the number of total sourced candidates and how many of those are now converting into interviews. And then I'd like to come back and show the number of how many of those interviews will be converted into hires. Question, Director Kenny?
Yeah, I'm still trying to get my head around this awaiting offers. So you're saying that now the current number is around 26 days, and the goal is to get it down to 3 days? Are those the right sets of statistics?
It was at 36.8 days on average. And across the entire fiscal year, we've now reduced it to 26 days, 26, what's my stat? Yeah, so almost 10 days. And so as we continue to drive the number down towards our 72 hours, I mean, our goal is to hopefully by year's end, or even, the start of the next fiscal year or mid fiscal year of next year, we want to be closer to that 3 days. That's our goal.
Okay.
We still have.
I don't need to get into the specifics exactly, but it just seems to me that to get from 26 days to 3 days requires some kind of a quantum jump. I mean, you can't get there by doing more of whatever you've been doing, harder or faster. You really got to change something fundamental. And what's the current thinking about what that fundamental change is?
We're bringing in more manpower with a third company.
Okay.
Deloitte. We finally have a final signed contract with them, and I think I mentioned that they would be coming probably towards the beginning of the year. So we have them finalized now, and we're hoping to have them on board when cross country and slalom join, so that we could have our trio here. That did not happen, and we didn't have enough manpower to help us push it through. So I think
it's primarily a personnel.
It is primarily a personnel. Okay. And we have also expedited or revised our hiring process. That's what Slalom has really been supporting us with, that, refining what we do, the number of steps, the number of processes. And so we've now trained more than 300 people with that new process. And now we're live with that as well, so that we can pull back on some of the things that we were doing. So a lot of it, Director Ketting, and to your point, I probably won't go into all of the details. It's just
That's
how
fine.
we work.
Okay.
And how we were working was a lot of duplication and double checking and triple checking on things that we could probably streamline. So we still maintain compliance with hiring standards, but we are streamlining our approach. We're adding more manpower, we're tracking it, and we're holding ourselves accountable as we attempt to, partner with the departments to host these events. So it's a multifaceted approach. That's why we're trying to drive that number down. Does that give you better clarity?
It is such an enormous change.
It is.
It's hard to fully think about it, but I guess the one thing I'm left with is if the process was so, whatever it was, skip the characterization, that it's possible to get it from 36 days to, say, 15 days even. It makes me shudder to think what other processes might be around in the institution that are inefficient by hundreds of %.
Dr. Kenny, I can add to that. I think there are a few. We're working through them as quickly as we can to give you just a little bit of a perspective, so that to review what your question, and I asked the same questions as we went through the processes. So I can just show you one of the things that we have found. The question you're asking is who are those groups of people? When and after we have fully complied with the employee plan, and a supervisor says, I want to hire this great candidate named Michael Ketting. I want him, he's my candidate. They've validated all the employment plan requirements, and all the vetting that has to go in those signatures. They create a decision to hire packet. That packet was returned to human resources, but that's where some of the challenges started. Where it was sometimes returned individually. It sometimes would sit. There wasn't a queue to make sure that things were moving forward. Things could get missed. Someone was on vacation. It sat. And so the inconsistencies on those processes was less than streamlined. And so then supervisors would be calling and they would miss calls. And so we have started to automate all those features to be able to track it, to create systems in place with the Valerie's teams working with our consultants to be able to streamline how those packets get entered, where they get stamped, how quickly they are, the review queue, the cadence to making sure that answers are happening, and it's improving. We have a lot more work to do. I think that because we have such, very thorough requirements from our employee plan that we have to meet, it sometimes creates some inefficiencies in our systems, but we have to find ways to make sure we're streamlining those and being as efficient as possible and automating where we can. And so I would say that I think what most of the improvement is coming is creating some standardization, automation, and then working with a team. And they're doing a great job in creating huddles and others to be able to make sure we're driving that movement as fast as we can. And so, unfortunately, there's a lot of those processes that you talk about. We can probably put together, hopefully when we finish and we see how we do in this real concerted push. And the reason we picked 400 employees is that would actually start to get us a little bit ahead of where we are, given our attrition rate. It would actually make a dent and improve it. We wanted to see if we could do that. And so we, at the end of that push, we can come back and give you what were some of the real insights to processes that really help make the difference. And we are monitoring those throughout the organization because we have some work to do. I'm not going to be earnest. We do.
Mm-hmm. Great. Thank you, Mr. Rocha. All right. So I mentioned again the revised hiring plan. That's some of our process improvement initiatives. Let's really work smarter, and as we maintain compliance, our virtual hiring events that are planned for August, we do have dates for those as well. So it's 0 at this moment because they haven't been completed. And then we'll look to increase the number of employee orientation sessions as we start to hire more external folks to bring into the organization. Next slide, please. Here's a highlight of the departments and the the areas that we want to focus on for our hiring events. So some are clinical and some are non-clinical. Primarily, most of them are clinical. Next slide, please. I just want to share this. I know it's not metrics related in terms of our standard, but I do want to just share. You have all received an invitation to our Providence Scholarship ceremony that will be held on August the 2nd. We're pretty excited to share that, again, Cook County provided $1 million for us to establish a scholarship fund, and we were able to do that by providing 3 programs. The first one was health professionals, which really identified programs for medical students. So the MD, DO, and dentistry programs. 13 scholars were awarded for those programs. We did have many more applicants for that program, but we did have some very, very strong criteria for all of our scholarships. And one of those criteria points was financial need, as well as social vulnerability index and a number of other factors. So pretty excited to share about that. The Undergraduate Allied Health Program, the award would be $10,000. And these programs covered dentistry, such as dental assistant, respiratory, radiology, and nursing. 7 individuals will be awarded out of the applicant pool, and we did have some that did not meet the qualifications there as well. High schoolers, we focused on not only Chicago public schools, but suburban Cook rather. There's a $10,000 award for those individuals, and 11 were selected. Various healthcare careers for the high school program. So we are very pleased to announce that there will be 31 in total. The event will be next week on Tuesday from 4:30 to 6:30. This is in honor of Dr. Daniel Hell Williams, our Providence Hospital founder. Thank you to the Board of Commissioners, President Preckwinkle, for all of the support, the CCH board, Mr. Rocha, and everyone who participated, the steering committee, who are a number of my colleagues, as well as Commissioner Deere, who was championing this program, Director Story, and many others. So thank you so much for allowing me to present today. Any other questions?
All right. Thank you so much. Thank you so much, Ms. Amos. I'll turn it back over to you, Chair Taylor.
Thank you.
I apologize. Please, I would like to also thank the foundation. They also contributed towards this particular fund, and they raised about $100,000 to also support the undergraduate and allied health program. So my apologies, I missed the foundation. Thank you so much.
Oh, thank you. Thank you, Ms. Amos, and also Director Prendergrass for a very robust report and discussion. And again, we look forward to the scholarship event on August 2nd. Next, Director Munar will review the Managed Care Committee meeting minutes. Director Munar.
Thank you, Chair. The Managed Care Committee met on Tuesday, July 19th, and we received a report from our health system, from our health plan CEO on the metrics. We will not review those again, but I will highlight some of the high points of the presentation. We reviewed the county care utilization, and in response to requests from the board, reviewed strategies around domestic spend. We also discussed 4 strategic domains, including fiscal resiliency, growth and retention, equity, and staff experience. And we had a robust conversation around strategies around redetermination once the state resumes redetermination, which we've been preparing for several months. We also talked about outreach, our outreach to current members around redetermination. And we're excited to hear about the county care's collaboration with the flexible housing pool. And we are presenting the minutes as part of the joint resolution, and we'll hold that for the combined motion.
Thank you
Any
very much.
questions or comments?
Looks like we don't have any. Thank you very much, Director Bernard. Next, Director Keding will now review the Audit and Compliance Committee meeting minutes.
The Audit and Compliance Committee met on Tuesday, July 19th, and the next meeting of that committee is Monday, October 24th at 9 a.m. The open portion of the meeting was primarily concerned with board education. Numerous entities require that there be an ongoing program of board education that in some rough way is parallel to the ongoing educational requirements for all employees. In the past, we have tried to get the board to complete modules of training, but in discussions with Nicole Almiro, who's the Chief Corporate Compliance and Privacy Officer, we thought that it might be more effective to use a meeting to focus on the training for at least the Audit and Compliance Committee. And so that's what happened at the last meeting. We still have to figure out how to encourage and get the same kind of training for the rest of the board. Not merely to meet corporate compliance requirements, although that's a good thing, but also because it is helpful to be refreshed on what those requirements are to make sure we're thinking about them as we go through our meetings. One follow-up note from that meeting was a question raised by Director Guggenheim about how do we know whether we have enough resources in this area. And a big part of the answer was that last year we had an external evaluation of the program. That's one of the reasons we do an external evaluation. And that report was discussed with the committee at the time, and be happy to recirculate that and answer any other questions that might exist about that issue. The committee also went into closed session, but there were no action items at the closed session. Some of the things will be reviewed when this board's in closed session, but because there were no action items, the minutes can be approved as part of the combined motion when we get to that. So, any other questions or comments?
Looks like we have none. Thank you very much, Director Keding. Next, Director Guggenheim will now review the Quality and Patient Safety Committee meeting minutes.
Thank you, Chair. Good morning, everyone. The Quality and Patient Safety Committee met on Thursday, the 21st of July at 10:30 a.m. And the next meeting of the committee will be on Thursday, the 18th of August, also at 10:30 a.m. We received reports on the high reliability organization dashboard and reviewed and discussed the metrics on the 30-day readmission rate at Stroger Hospital, the case mix index for both medical and surgical DRGs at Stroger, the top box score, which was recommending the hospital, and the HbA1c diabetic scores. As a follow-up to those discussions, Ms. Frainer is going to get back to us regarding a sort of rather extraordinary blip that happened in August 21 when the top box score went up very high. We wanted to sort of investigate and see if we knew the reason for that. We also received a regulatory and accreditation update that was highly satisfactory. We received executive medical staff reports from both Stroger Hospital and Providence Hospital, and the action items were the approval of medical staff appointments, reappointments, and changes. We went into closed session to discuss some aspects of patient safety, but there are no plans to re-review that information today. So the minutes that are being presented for board consideration as part of the combined motion can go into the combined motion at the end of the meeting. Any questions? Hearing none, okay, that concludes my report.
Thank you very much, sir. Thank you very much, Director Guggenheim. Next, Director Ryder will review the Finance Committee meeting minutes.
Good morning, everyone. The Finance Committee met on Thursday, July 21st at 9 a.m. The next meeting of the committee is going to be on Thursday, August 18th at 9 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved 23 contracts and procurement items. Number 4, 11, 13, and 20 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting, whose fiscal impacts are greater than $1 million, which are highlighted for your information. Regarding request number 12, the Slalom LLC contract, request was made to receive a 3-month interim report on status and activities to be provided either at the next committee meeting or in the interim, possibly will be presented at next month's Human Resources Committee meeting. Regarding request number 13, the VIA Workforce Solutions LLC, formerly Vizient, request was made to receive an update on the status of whether timely payments are being made. Additionally, a request was made for a report regarding the timeliness of VIA in filling the staffing gaps for Cook County Health. Of note, there was an amendment to the fiscal impact not to exceed amount for request number 13. The request is being increased by an additional $5 million, bringing the total request not to exceed amount to $75 million. We received and filed grant reward related items. We received and filed transfer of funds. The committee received the following reports, which are also included in the minutes. Minority and women-owned business enterprises reports. We had 3 emergency purchases, which were reported, and a report of the May 2022 year-to-date financials. I will also say that we were fully engaged in a new process where the sponsors of our contract items all were there to present their contract items, and we, I believe, had a very informative and engaged session. Very good, tweak to how we do this. The action items, reports, and presentations from the committee meeting are included in the meeting minutes. If there are no other questions on the information, the minutes are being presented for the board's consideration as part of the combined motion to be made later in the meeting. And that's all I have, unless there are any questions, Mr. Chairman.
Thank you. It doesn't look like we have any questions. Thank you, Director Ryder.
Awesome. Thank you.
Perfect. There are no contracts being presented directly for the board's consideration today. So if there are no other questions on the minutes and action items contained within the minutes, we can move on to the combined motion. Hearing none, I'd like to entertain the following combined motion to approve the following. Item 5A, June 24th board meeting minutes. Item 5C, July 29th Managed Care Committee meeting minutes. Item 5D, July 19th Audit and Compliance Committee meeting minutes. Item 5E, July 21st minutes of the Quality and Patient Safety Committee meeting, which include the Stroger and Providence Hospital medical staff appointments, reappointments, and changes. And item 5F, the July 21st meeting minutes of the Finance Committee meeting, which include the contracts and procurement items, grant award related items, and transfer of funds.
Move the combined motion.
Seconded, Dr. Garrison.
Thank you. The combined motion has been made and seconded. Madam Secretary, please take a roll call vote on the combined motion.
Roll call vote on the combined motion. Aye or nay, Director Curry?
Aye.
Vice Chair Deere?
Aye.
Director Garza?
Aye.
Director Guggenheim?
Aye.
Director Harrington,
Aye.
Director Kim is absent. Director Keding,
Aye.
Director Munar, Director Munar.
Aye.
Thank you. Director Prendergast, Director Prendergast is absent. Director Ryder,
Aye.
Director Story,
Aye.
and Chair Taylor.
Aye.
So you have 10 yeas and 2 absent.
Thank you. The ayes have it. The combined motion carries. Thank you all. The next item is a quarterly report from the Cook County Department of Public Health, which will be reviewed by Dr. Lamar Hasbrook. Dr. Hasbrook?
Morning, directors. I think there is a, there's a slide. Okay, here we go. Thank you. So we just want to highlight some of the work that we're doing in one of our grant programs called Building Healthy Communities. The goal is really to partner more tightly with the community in more authentic ways to support organizations in moving forward evidence-based programs, policies, and systems, and to, again, build this trusting, sustainable relationship with these communities. Some of these we've started really codifying during the COVID response, but we want to kind of build on those and helping to give them the resources that they need to have the opportunity for health. Next slide. So again, we braided together 3 different sources of funding: ARPA funding, which is highlighted here, also CDC community health worker grant, and some COVID crisis funding from the state health department. And on the left, you'll see there's a number of different strategies. This went out as like one combined RFP. A number of different strategies that folks were eligible to apply for, and they're listed here on the left. Health equity in all policies is something that was not taken up by many of the applicants, but you can see some of the other ones: community health workers and other innovative strategies and things. So we'll talk a little bit more about this going forward. Next, please. So to make sure the money went to the right areas, or the most priority areas, we use this map that you're probably very familiar with now, and looking at social vulnerability index. We've identified 35 municipalities, primarily in those areas with the highest scores, social vulnerability index, meaning they need more resources to be able to thrive. So those were in the West and the South regions, no surprise there. Next slide. We did consider other jurisdictions in terms of, if they had a very creative or innovative justification or need. So the application screening and decision-making process went as follows. There were 66 applicants. They went through an eligibility screening for our vendors. 44 were recommended for scoring, and then 41 of those were recommended for funding. There was a weighted ranking system, again, given the priorities, given the areas of interest and things like that. And then ultimately 39 were recommended for funding across the 10 different strategies. Next slide. So some of the decision-making factors, population and communities that needed, needed that reach or that touch. Those that really could, demonstrate that they could really benefit from these monies. And then other factors were things around their capacity, their track record, fiscal responsibility, things like that. The work plan, how tight were those work plans, the actual strategy, and then other letters of commitment as well. So again, a very comprehensive scoring matrix, if you will. Next. So this is how it shook out. $7.4 million were allocated. We didn't actually expend all of the funds, and we'll talk a little bit about that in a second. 39 CBOs were funded, and their awards range from 50,000 on the low all the way up to 483,000. The bullets on the right really tell you kind of where the money went, and they don't add up to the 39 because a number of them had different or a number of different applications that they funded. So you see most of them went in the South region and the West region, and then there were a few that went to the North region. Next, please. So this is the breakdown, and again, we cobbled together or braided together 3 strands of grant funding. So the CDC Health Equity Grant is the first panel, followed by ARPA, and then the CDC Community Health Worker Grant, and then some COVID crisis grant funding. And you'll see in the far right column kind of the total that came from those respective grants, and you'll see the strategies that these CBOs really went for. So a lot of them, as you might imagine, are still working in the COVID space and program and services related to those communities that are distressed or need additional support. Community health workers was a very popular one. Mental health, an emerging area of interest for us at CCH, as you know. Positive youth development, which could relate very nicely to the violence prevention work we're doing among youth, and we're expanding. So it just kind of gives you an idea of what strategies they wanted to get funded for and how the money broke down. Next slide. So our long-term goals, again, is to strengthen the capacity. We want to work with them, partner with them as they identify their priorities. We gave them, a menu of 10 different things. They were able to choose for those things that actually meant the most to them, that they wanted to address. Building what we're calling a regional learning and action network to customize technical assistance and to really share learnings among the folks, the grantees. To encourage networking and collective action, peer-to-peer learning, because everybody's working in their jurisdiction on some strategies that may overlap, but there's an opportunity to really amplify those learnings. We also want to make sure we're continuing to build stronger relationships with our communities, not only when we have money, but even when we don't have money. We want to be of service. We want to be able to reach out to those folks when we have to activate them for things and give them increased information, like with monkeypox and other things that might be emerging priorities. So really build these authentic relationships over time, increase the power sharing and building between us as a potential funder or certainly an ongoing partner in the communities that we aim to serve. And then the sustained level of community solutions. And so, we see ourselves as growing partners, kind of a snowballing approach with every grant opportunity, with every public health initiative or health education initiative, just collecting more and more credible relationships so we can help be of service to the communities that we serve. And I believe that's it. Next slide. Yes. So that's my presentation. I'm happy to answer any questions or clarifications. Thank you.
Thank you, Dr. Hasbrook. Looks like you're off to a fast start here. Actually, see, you do have questions more. Director Keddy.
Yeah, I don't know whether this is a question or a comment, but it does strike me that this is kind of a difficult proposition, because it's not clear how many whether we're going to have this kind of funds in the future to give out. And if you give big enough money to have scale, then the organization's going to be left high and dry if we don't have money in the future. But if you get a lot of small grants, then they don't necessarily have scale, and I wonder how they get together. So I wonder how you thought about that, and particularly how you're looking forward to whether we will have more funds to give out in subsequent years.
Right. So I think my perspective, and a lot of this work obviously started before I got here, but my perspective is anytime we have funding, it's an opportunity to partner in a more transparent and authentic way with the community. We have, kind of an exhaustive vetting process, if you will. You saw various different scoring criteria. And so we're not trying to give money to mom and pops that are kind of one-off that may not be able to really manage the money and, absorb the money well. Those that really have a foundation, some capacity to begin to build upon. So we see this as an injection, not only the money, but the technical assistance, the network that you build from the shared peer-to-peer learning. So we're looking at capacity that lasts beyond the money. And then also the experience of learning how to better apply for funds, manage funds, which puts you in a better position to go out and get additional funds that may be from us, the state, or other, other foundations. So that's really the big win, and the incremental change that can happen along these specific tracks and strategies. So that's kind of my thinking. We're not giving money to, kind of a one-off that then going to implode when the money's gone, And then we also want to make sure, as we're building these engagements with communities, that they will avail of the other health information that we have. Again, the mobilization, the activation of the community around other broader health issues and conditions. And so we really look at it as a platform and opportunity to get more entrenched in the community. So that's kind of my perspective on it.
Good. Thank you.
Thank you. Director Harrington.
Dr. Hasbrook, it's good to see you. Two things. The social vulnerability index that you mentioned in the map, would it be possible to overlay where those grants went relative to the map, so we can not only just see the map, but see where that funding sort of went? And then the other thing, I like what you're saying, and I would welcome you to come back maybe in 4 months, 6 months, to give us some idea of how things are working, what your problems are, and if there are problems that maybe we could help you address moving forward. Thank you.
Great. Yeah, thank you for both of those. Yes, we actually are in the process of doing that, putting pinpoints on the map where the CBOs actually are. We didn't have enough time in preparation for this, so we will be doing that. And I would say, yes, we'd be happy to revisit or share kind of progress to date. 3 to 6 months into the program. Looks like we may not roll this program out until around October, November, but we'll certainly get on the calendar to give you a 3 to 6 month look in terms of how things are going.
Thank you very much.
We have any additional questions? Again, Dr. Hasbrook, thank you for the thorough report and the fast start. We look forward to continue to work with you and support you in any way we can.
Thank you.
Thank you. The next item is my report. Yesterday at the Cook County Board meeting, a resolution regarding an assault weapons ban was approved by the County Board of Commissioners. I asked that this resolution be sent to you yesterday, so you each should have received it. With the intent of requesting this board's consensus of support for it. But first, I'd like to open it up for comments for any directors if they like. If you received it, if you had any comments.
Director Cutting here. Yeah, I think this is a very important issue for us to weigh in on in support. I think we're all aware of the problem of gun violence in Illinois. I'm not going to belabor it. I think that this is not likely in and of itself to dramatically get at the root causes of most of our gun violence, but we need to do whatever we can in order to rationalize Americans' gun laws. And this is such an obvious step to take, I believe, as a health entity where we face not just the number of fatalities from gun homicides. There were over 1,000 in Cook County last year, but also the enormous cost that a large portion of which winds up gets borne specifically by the Cook County health system of fatalities and non-fatal injuries, which have long tail of costs in the hundreds of thousands of dollars for many people who live. So I think it's important for us to get behind this. Thank you both. President Preckwinkle and the other commissioners who pushed this forward, and Chair Taylor for getting it on the agenda today.
Thank you very much, Director Cutting. I think in order, I'm going to try to see, we have a number of hands raised, so I'll try to go in order here. Next, Director Guggenheim.
Sorry, I just want to second everything Mike said. I mean, any little move, however modest, to raise the issue, to reinforce the majority opinions, to counter NRA propaganda, on and on. Yes, let's do it.
Appreciate that. Thank you. Next, I believe Director Harrington. You're muted, Dr. Harrington.
I think it's important for us to do as a matter of public record so they know that this is something that we as a board do in fact support. I'm giving a talk on Sunday at my church. I am going to be talking about gun violence to an extent. And I saw an article in the Washington Post that reported, and this was one day after the tragedy in Highland Park, that in 2021, there were almost 700 similar incidents. So we probably don't really realize, and there is no definition for what constitutes a mass shooting. Is it 4 people? Is it 17 people? So we really have a problem in this country. And again, I think it's important for us to go public and make a statement. And I applaud the board, for Cook County Commissioners, for doing that.
Appreciate it. Thank you for your comment. Next, Director Curry.
Just wanted to support the previous comments that were made. I think it's extremely important that we weigh in on this in a public way. And so I'm extremely supportive of this resolution. And this may be fundamentally one of the stepping stones that need to be taken. And I'm sure there'll be others down the line, but very, very strongly support this movement. Thank you.
Thank you, Director Curry. Any other comments? Well, as you can, probably surmise the fact that we have this on the agenda, I strongly believe that we should actually voice our support for anything, as everyone said, anything we can do to minimize, to curb, even one injury, one life, anything is quite important. Given that, I like to ask for the board for your consensus via a voice vote in support of the resolution. All in favor?
Aye.
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 All opposed? Thank you. Let the record reflect that the consensus of the board is in support of this resolution regarding an assault weapons ban that was approved by the Cook County Board. Thank you. The next is the report from the CEO. Mr. Rocha.
Yes, hi. Good morning, everybody. I'm going to start for a quick second. Just going to pull up a slide, and today, just to provide a little bit of navigation through the report, I'm going to start with a budget update, and then we are going to recognize some of our leaders to give an update on monkeypox. So if you can go to the slide a little bit after, so move through that a little bit. There you go. There you go. So I wanted just to start with today with the bulk of my report being a budget update, since we are we have given our mid-year budget review vote to the county. Wanted to make sure we also informed our board. So I'm pleased to be here today, and want to start by thanking, of course, all of our members across Cook County Health, our finance committee, our finance chair, our board for their leadership. I'm pleased to report that our finances are strong. We are ahead of budget at mid-year and fully expect to end the year balanced. As you're aware, County Care's membership remains well above budget, primarily due to the fact that redetermination remains suspended under the public health emergency. However, we are making plans when this emergency were to conclude, and we would resume back to normal operations to ensure that we continue to have a robust membership and provide services throughout the community. There remains a good amount of uncertainty in the job market. I want to stress that every health system in America is dealing with workforce shortages. You saw those today in the report by our Chief Human Resources Officer, Valerie Amos. These challenges require us to double down on our recruitment strategies and look at our entire compensation package and structure so that we may have the opportunity to attract the talent we need going into the future. I am very pleased to report that yesterday the Cook County Board of Commissioners passed a resolution that will give its different organizations, including Cook County Health, an ability to pilot some new strategies to recruit and retain the workforce with new opportunities to be able to be competitive in the marketplace. We will continue to work with the Bureau of Human Resources, and I'm committed to ensuring that we hire as many new employees as we need to allow us to grow and to be responsive to our patients' needs, to our community's needs, to building equity, and also, most importantly, to addressing critical needs in the community where Cook County Health is needed most and was built for, like COVID and monkeypox, to ensure that no one goes without the care access that they need. And while I wish it was not the case, speaking of these elements that we have to confront, COVID is again surging in our community. We are experiencing slight increases in hospitalizations. Just this week, we had to open an additional unit to be able to mitigate new admissions related to COVID. The positive news is that these require medical treatment, and we are seeing a record low of deaths related to COVID, which means that the vaccines are working. Individuals who have been vaccinated, we are able to stave off some of the most complicated conditions related to the COVID virus. However, the BA4 and BA5 subvariances comprise more than 70% of the new cases. And as has been the case, vaccinated individuals are faring better than the unvaccinated. I'm thrilled to report that following the FDA and CDC approval, we are now vaccinating the youngest children. Booster shots remain available at Cook County Health locations through our CCDPH partners and in commercial pharmacies for approved populations. Please encourage everyone who you know and everyone who's listening today and everyone who is eligible to, if you have not yet, to get your booster and make sure that you are caught up to date on all your boosters for your best protection. We also look forward to federal approval shortly for boosters for those under 50. In the meantime, please remember to do what you can, which includes washing your hands, remaining masked, observing your distance, observing rules in enclosed spaces, and doing everything we can to keep everyone safe so we can all get through this together. We are also building capacity to vaccine, test, and treat for monkeypox. You will hear more about this in a presentation from our staff just shortly. We are monitoring this closely and will add additional strategies as the situation requires it. I want to spend a minute to also give an update about the Change Institute and hopefully generate as much excitement amongst our team as we have throughout the health system. We have launched the Institute in April, and we have identified leaders that have begun to implement changes that will enhance the patient experience and create true centers of excellence in cardiology, neuroscience, cancer care, in an effort to address the deep disparities that exist amongst our patient population. What I want to make sure that we highlight today is that Change Institute wants to do things new in a different way. We know that there are drugs, there are things that we can do to help combat critical conditions like hypertension in minority populations. When we look to the community and we see an age disparity of over 30 years between communities with great resources and those that do not have them, we know that some of those things we need to work on directly. The entire community is working to bridge things and social risk factors and social determinants. But the Change Institute also wants to take it a step further. Just like in COVID, when we knew that we had a vaccine in hand that could be able to save your life, we know there are medications that we can give to help save off the most complicated conditions of hypertension. We're able to do that in diabetes. We're able to diagnose cancer earlier and to give these treatments that we have in hand today. They can make those differences to ensure that those lives don't have to be prematurely lost 30 years earlier because there was a drug that was available to control your hypertension, to help you with your heart, to reduce your cholesterol, to get the things that you need to save your life today. It can be just as simple as getting the drugs that people need, finding the populations that need them, and getting them into the medical care that they need. For almost 70 years, we have not rechanged the way that we engage in medicine. We still go to a doctor's office. We still call. We wait for hours. We go for one visit, another visit. Then we have to navigate through specialists. And then finally, if we need a surgical intervention, we go for pre-admission testing, and then we go get tested. That requires almost a full dedication to being well and healing and feeling better. We need to challenge ourselves to make this easier, to find new ways to bring care to patients who need it, especially those who, given the circumstances that they have to live through, have already additional challenges in living and being and remaining healthy. Healthcare should not be another crucible that people have to care. We need to make sure that healthcare is advanced. That is the change we are talking about. Getting the powerful strategies that exist, finding the ease of a modality to be able to do it, and to make sure that our system delivers the equal care and the world's best medicine available to everyone. So that as the board has approved our strategic mission, healthcare, health will be a human right. And so as we look forward to improving these services, working with our team, bringing new innovations like TAVR and aortic valve replacements and things that we have not done to advance our services, and even the most simple things to reinventing and revolutionizing the way people access medicine. That is what the Change Institute's about. That's what these leaders that we have selected are helping to pioneer every day. And we hope to have some exciting updates for you to show you what we're already doing as we have had conversations with many partners and things are moving forward. I finally want to end by thanking the Cook County Health team for their continued dedication and commitment all the way through, not just to the middle of this year and not just to this budget review, but throughout the last few years. The last few years have tested the healthcare industry in a manner that no one was prepared for. Our team, from the staff who maintain our facilities, to those that clean the rooms, to cook our food, to the contact tracers, our mental health specialists, our respiratory therapists, our lab technicians, our doctors, our nurses, and everyone in between have responded with grace. They remain deeply committed to empowering the change and healing that Cook County Health needs. We are all deeply proud of their service and the amazing things that they have done. And I would also like to end by thanking the board for their steadfast commitment and dedication to ensuring that every employee at Cook County Health and every patient has the resources they need and has helped us find a way to make sure that we remain a beacon of hope and healing in our community. Thank you so much for today. Well, I'm now going to ask if there's any questions in reviewing our budget review, and then in the next part, we will recognize some leaders to give an update on monkeypox and what we're doing to be able to combat that. I see a hand raised, but I don't see who it is.
Dr. Guggenheim, Director Guggenheim, your hand is raised.
Director Guggenheim?
I just hadn't put it down.
All righty. The next slide, I just also wanted to make sure that we shared with you before monkeypox to inform the board that we are also going to be releasing a complimentary set of grants. You heard Dr. Hasbrook talk about the set of grants that are being released from the CCDPH. Cook County Health also has some set of grants in ARPA. Our grants are a little bit smaller and would be based for some of the communities. We had a set of 50 proposals that were submitted. 43 have assigned to scoring, and it will be going into individual review and panel review. 19 have been identified for final decision. 13 CBOs are funded across these strategies. The strategies and scoring modalities included the CCH Community Social Vulnerability Index, balancing geographic reach with citywide and hyperlocal services, work plans that demonstrated increased impact with additional funding capacity, attention to targeted populations, including LGBT communities and immigrant families, and avoiding bias to prioritize larger populations. One of the differences between ours and the cities is that ours are available to everyone, including those populations within the city, since Cook County Health is a county-wide healthcare provider. And so we are happy to just give you an update. We will be bringing these forward. We're very excited by the proposals that we had, and these will be small grants that will enable transition within the organization to be able to reach and maintain the changes and programs that they wish to seek. And we'll be providing more information once they're fully awarded. Then with that, I would like to recognize Dr. Sharon Wellbell, who is our Division Chair for Infectious and Hospital Epidemiology, Dr. Lamar Hasbrook, who's the CEO for the Cook County Department of Public Health, and Eliana Mora, our CAO for Ambulatory Services. And first will be Dr. Wellbell.
Thank you, Mr. Rocha. I'm going to briefly talk about monkeypox, the global outbreak, what we are doing to protect our patients and staff, how we are preparing staff and serving our patients. WHO has now declared monkeypox a global emergency to facilitate international efforts at controlling this 2022 outbreak. As of the 27th, you can see there are over 20,000 cases in 77 countries. And of note, the majority of these cases are in 71 countries that have not historically reported monkeypox virus, indicating a huge shift in how this virus is being transmitted. In the US, there have been now 4,907 cases. Illinois, as of today, 414 cases. Chicago, 300 and over 300 cases. And what we know about the epidemiology to date is that 99% of these infections are occurring in men, and that they are and 98.4% are occurring in men who have sex with men. Next slide, please. The monkeypox virus belongs to the orthopox virus genus. This is a double-stranded DNA virus, and the reason I even mentioned that is because COVID is an RNA virus, and sometimes I hear people conflating the two. This can be transmitted by breathing respiratory droplets from an infected person, but that generally is limited to household contacts because transmission via respiratory droplets requires prolonged contact. In the 2022 outbreak, it has largely been transmitted by close contact with lesions or bodily fluids. And our most common symptoms in this outbreak have been rash, malaise, fever, and lymphadenopathy or enlarged lymph nodes. Next slide, please. So we have been preparing our staff. We also have been making sure that we're protecting our staff and our patients by quickly identifying patients who come into our facility who might have monkeypox by asking a number of screening questions, and that helps inform and facilitate rapid isolation of these patients. And then we make sure that we inform infection control and or infectious disease. We're accomplishing these things by educating our staff. The infection prevention control team has been educating healthcare providers, including physicians, nurses, ancillary services, ambulatory and correctional and health personnel. Personnel from CCDPH has also been providing much education. We have completed an LMS, and this is required by all staff. The communications team has kindly put up and maintains a monkeypox intranet site that my team and I have populated and update regularly. And there has been training and on sampling and safe handling of lesions for molecular diagnostics of the lesions that we see on our patients. Our goal is for all staff to understand what monkeypox is, how it is transmitted, prevented and treated, and how to dispel myths. Next slide, please. So we are serving our patients by partnering with the centers, CCDPH and the Centers for Disease Control and Prevention. The core, ACH and CIRMAC are all at different levels of preparation, but currently we are diagnosing monkeypox. We've done a lot of education, both at the core, ACHN sites, and now at CIRMAC. Supplies for sampling the lesions have been provided. All these sites now have vaccination, mostly at the core center, where we have a vaccination clinic for post-exposure prophylaxis, the acronym being PEP. There's also for what is called PEP++, which is expanded post-exposure prophylaxis. That's what it's called. I look at it as pre and post-exposure prophylaxis because this is for the group, the most vulnerable group, who are likely to have monkeypox transmitted to them. So men who have sex with men, who also have sex with multiple sexual partners, sex at social venues, who trade sex for other commodities, and so forth. We do have treatment available at the hospital and at the core center. We provided some to the jail recently This is called tecovirimat, the branded as T-Pox. This is an antiviral medication. It is not currently FDA approved for monkeypox, but used in conjunction with the Centers for Disease Control by expanded access IND. And the vaccine that I mentioned is Yanios Vaccine, and this is FDA approved for the monkeypox virus. We first received it July 11th. We have given over 200 doses over there. There's also been a handful of doses given out through the ACHN clinics, and we still have a number of doses left, and we continue to get more supply via IDPH and CDPH. Next slide. Thank you.
Thank you,
Dr.
Dr.
Hasbrook?
Wellbell. Yes. So just to build on the previous comments, so let's focus in a little bit on what's going on in suburban Cook, which is our jurisdiction, as you know. So on the on the bottom left is our epi curve, as modest as it is. And you'll see that we got our first case the week of June. Each of these bars represent the entire week. I think our first case was June 24th. And ever since that time, we set up our incident command system, and we've been meeting every morning at 8 o'clock since then. So we're paying very close attention to this. But you'll see kind of our epi curve here on the left. In total, we've had 20, actually now this is up to 31 cases of residents in suburban Cook. These numbers are going to change a little bit because they're always moving, depends on when you look into the database. Next slide. So much like we're seeing globally, much like we're seeing nationally, when there was information about sexual orientation or sexual identity, 61% of our 26 cases here, we're up to 31 cases, have self-identified as gay, bisexual, or men have sex with men. There's a good swath that didn't report that data is missing, and then one person self-identified as straight. So again, we're seeing all of our cases up to this point have been male. So again, holding trend with what's going on the global and national levels. Next, please. So a lot of messaging considerations, because as has been said, Mr. Rocha emphasized it, you really have to make sure you get the information out there so that we're laying fears of the well and those folks who shouldn't really be at risk and shouldn't be lining up for a vaccination. So the transmission has been mentioned. The symptoms has been mentioned. Again, the global trends are emphasized. 98%, this is WHO data, 98% men who have sex with men. Most of it is transmitted sexually. We don't consider this a sexually transmitted disease. It is a skin-to-skin, close contact transmission. So that's probably what's happening there. There's no evidence that it's in semen or vaginal fluids at this point in time. So it's not a traditional STD, but again, that close contact, skin-to-skin contact and close, prolonged, intimate contact is really what's happening here. And again, you can see, much as we've seen, our age, our adult men, somewhere between 20 and mid 50s or so. So again, holding up with the national and global trends. So we're making sure with the messaging, the purpose of this slide is to say that anyone that has close contact with a known case can get it through a number of different routes of transmission. Again, close, prolonged, intimate, personal contact. But we are seeing in the data that there are most of the cases, the vast majority are among men who have sex with men. So we want to be careful in terms of our messaging and make sure that we're reaching everyone, because everyone's at some amount of risk. Next slide, please. So what are we doing for our jurisdiction? So we've been scaling our educational materials. Again, we're working collaboratively with all of the partners, as have been mentioned. But we're making sure that we're scaling the educational materials and community outreach. We're going to be moving more into social venues. A lot of infographics are going to be coming out in the next few weeks, direct channels, doing the surveillance and contact tracing, because for every case that you have, you want to do what's called ring vaccination around all the contacts that they had. Again, trying to break the chain of transmission. Vaccine storage and redistribution. So we are able to draw down from the Strategic National Stockpile through IDPH, get our allotment of vaccines, and then make sure that vaccine can be coordinated to all of our partners, including ACHNs that are serving suburban Cook. We're also working with the other certified local health departments and their potential partners. So we have received to date over 700 doses, and we have vaccinated now over 31 kind of directly, and we've coordinated vaccines from almost up towards 150 now. And that is because a lot of our residents like to receive care or may receive care in the city. And we're working out the kinks to make sure none of them are turned away when they go to a clinic in the city by backfilling any vaccine that might be used on suburban residents. So we have those partnerships in works as well. We've coordinated or approved TPOXX, the medication for those who actually have the virus, who are going to be having serious illness or risk for serious complications. So in 7 patients there, working with ACHNs, you'll hear more about that in the next subsequent slides. And again, making sure our local health departments have the technical assistance they need, the clinical guidance they need, and the vaccines that they may need as they work with their partners. And then also we're planning some live social events, Q&A events. We may invite some of the board members to partner with us on these as we try to create some live venues so we can, again, answer questions in real time for these populations at risk. Next. And I will turn it over to Ms. Mora.
Good morning. I will lead you through what our plans so far are in terms of the community program. So we launched the community program on July 9th, so earlier this month. We focused, of course, at the Core Center in phase 1, where we are serving, as you can see, the high-risk populations. And we have been offering both vaccinations and treatment of monkeypox. From the numbers, we have actually tested more to that now. That was towards the beginning of this week, but the numbers have increased in terms of treatment and vaccinations at the Core Center. We are closer to about 140 vaccinations at this point from the Core Center. The core team that has been the model of care in terms of taking care and providing the community program is we have a advanced practice provider. They oversee the testing and treatment component. We have a nurse who helps and supports regarding assessment. And then we have a medical assistant that helps with registration and vaccinations as well. This program is going well. It was launched again in partnership with CCDPH. We recognize, though, that we need to expand and be available to the rest of the county and Cook County residents as we monitor the spread of monkeypox and therefore are planning phase 2 and 3. Phase 2 of the program would expand to, if we advance the slide, the southern part of the county where we also have HIV services available in our south suburban clinics. And we would expand it to, if we advance the slide to the next slide, we would expand it to the southern, as you can see, Blue Island and Cottage, but also North Riverside. And we would use, for phase 1 and phase 2, we are using existing staff, given that the numbers at this point are somewhat manageable. And again, providing the same level of services, hoping to expand that to those locations in the South. Moving on, though, we are preparing to expand to phase 3, which is the next slide, and that is to have access to both treatment and community vaccination program at not only Blue Island, Cottage, and North Riverside, but also in the northern part of the county, Arlington Heights, and then 2 city locations, Belmont, Cragen, and Sinkstack. For the city locations, we would work with CDPH to have access to the vaccine, which we're currently working with them now. And for the suburban locations, we would work in collaboration with CCDPH. In terms of the other aspects of the program that we are planning, not just the treatment within our own and vaccinations within our own locations, but we are also working on the development of a microsite that would allow community residents to book appointments either for treatment or testing or for vaccinations, very similar to how they currently do so for COVID vaccine and testing. Additionally, we are going to be working on a hotline in case we have community residents that have questions and need answers and are looking for information. That hotline will be available to them to assist with answering any questions that they may have. Moving on, the third phase of the project does require us to contract agency staff and to support us in that model that I explained, an advanced practice provider, a nurse, and a medical assistant in each one of the ACHN locations, as well as contract agency staff to help us ensure that we have the right number, not only for patients wanting to schedule live over the phone. So we have begun the recruitment of that agency staff to be able to deliver that expanded service at those expanded locations. And of course, as I mentioned, there will be additional costs that we're looking into, everything from the microsite to the transporting of the labs, etc. This is a high-level view of what the community program looks like and what we are currently planning and hoping to implement in the weeks to come. Thank you.
And that concludes our report. If there's any questions? I see a question.
This is Director Harrington. I have a couple of questions.
Please go ahead, Director.
Pardon me?
Go ahead.
One is, I haven't heard anything. Well, there are two. One, what is the potential for reinfection? If you get it, do you develop any immunity? Can you get it again? And the other is, it appears that the mortality rates are really pretty low, that you get it, you recover. And so that's one thing that people don't have to worry about. I think for me, the thing that's been the scariest is the images I see on television of people with monkeypox and how their bodies are speckled with pox all over them. And so that scares me more than anything else. But it appears that the mortality rate is fairly low, if there's any mortality rate. And what is the potential for reinfection?
Dr. Wellbell, why don't you take that one as our infectious disease doctor?
Yeah, thank you. The mortality rate is low. There are two clades or versions of this virus, one from West Africa and one from Central Africa. There have been some mutations in the last 8 years, but what we're seeing is the clade 2 from West Africa, and the mortality rate is very low. There, to date, we haven't seen deaths outside of Africa due to this. There have been some deaths in Africa. Largely, those patients also had HIV. It is supposed to be an immunizing disease, so hopefully people who have appropriate immune systems will not get it again.
Thank you.
And one of the notes just that what we are watching for is the recovery time. We want to make sure that, and Dr. Wellbell and Dr. Ezra can add to this, anybody who gets infected really shouldn't be out and about. And so this is a time to be at home. If you should become infected, it really is highly suggested that you remain quarantined at home. And so the recovery time can be 1 to 3 weeks. And so that's something we would have to monitor and look for in our workforce as well. So we need to be careful. If the numbers get larger, that's one of the bigger issues. But you're correct. One of the positive notes right now is that it is very, very low mortality. But you don't want to be out if you should become infected, as you said, with the sores or lesions that develop. And I don't know if there's any other comments from that.
Yeah, so the lesions, which is what is the most infectious versus the respiratory droplets, it's really been largely in the 2022 outbreak, close contact with the lesions. Secretions also can be infectious, but it seems to be the lesions. And so the lesions actually have to be completely epithelialized, or you have to have like what looks like normal skin over where the lesions were to be considered non-infectious. And in fact, even the scabs from the lesions carry live virus. So handling of sheets, towels, and so forth has to be done carefully.
Other questions? All righty. Then Chairman Taylor, that concludes my report. And
Thank
the full report is submitted for the board.
Thank you very much, Mr. Roshan, as well, Dr. Wellville and Dr. Hasbro. Thank you very much for the thorough update. We will remain, it looks like we do have a question. I'm sorry, Director Guggenheim.
Yes, I'm sorry. I've been sort of mulling over previous information we've been given this morning. And I was thinking about this scholarship program that we're doing. I don't have any sort of expertise in this field of financial support for students, other than the fact that I'm now at the stage of life when my grandchildren are contemplating college and postgraduate degree costs and so on. Is there some science behind the level at which these scholarships are given? I mean, do we know that these relatively small sums are sufficient to make a difference for individual students? Because I ask myself, wouldn't it be better to give larger amounts to a smaller number of people if that guarantees that they actually get through and graduate? And I suppose there is a science around financial support, but I have no idea what it is. And was it in fact used in setting the amounts for these scholarships? I don't know if anyone has the answer to this question.
So I can start a little bit, and then we'll definitely defer to Valerie and our team. But what we looked at was for them to be substantial enough to be able to cover most of the gap that institutions require that is paid. And so you do have a lot of financial assistance that is given, but even then there's student contribution and family contributions, and those usually can be around in this range. And so this really helps to cover books, expenses, those types of things. We are looking, and I know that both President Preckwinkle and even in the conversations we have had with Dr. Story in his role as the Deputy Chief of Staff to the President, we continue to work with the County Commission to see and also with the foundation to try to get additional money that will be donated. And so we had a set of scholarships this year. The foundation came in with a little bit more. We hope to continue to raise more money. We are working with other partners. As we do that, we'd like to have the scholarship evolve where it's guaranteed over multiple years, where it has the funding, where it can increase to full cost. And so that's why we work very closely with them to see how we can get there. And so I think that this is a start. We will be evolving to look and see that we are fully covering the needs. And if there needs to be adjustment, that will be brought back to the organizing group to make sure that we can make those changes and ensure that we're giving a scholarship that really covers any additional costs or expenses that make it burdensome for someone to complete the journey. And the levels that we looked at was to create that thorough pipeline, to be able to create not just from medical school, but to look at when people are going to college and then to medical school and all the way through completion. And we started all of them simultaneously so we can build towards it. But we hope in time it will be an ongoing program that could help an individual who would otherwise not have attended because of this financial burden all the way complete through medical school. And most importantly, hopefully finish medical school without a lot of debt so that they could be able to work in these communities. And then we're also going to look at whether there's incentives to maybe do forgiveness of debt in the future as well that might, if we miss someone on the way up but want to start tomorrow working with us, might be helpful. And so we'll be looking at many different ways to ensure that individuals who come from the challenges that are blocking them from entering medicine are resolved, and that these financial burdens do not preclude them from entering the service. And we'll work with them very closely. We'll look at we'll monitor the amounts, and then we will always be moving into the future. And then our goal is to make it guaranteed over the program that they work.
Well, thank you. I hope that we do actually keep a database and track this, because I mean, one reads all the time about the chilling effect that incurring debt for graduate education, particularly if people already have debt from their undergraduate studies. And it just seems to me that we're trying to do an awful lot with a relatively small amount of money, and whether it makes a difference or not seems to be important in the long run.
Well, I'll tell you, someone paying for college $10,000 and we're thinking about the need. This also one of the considerations will be it's a lot for the communities we're targeting. It seems like a small number, but 10,000 is a lot for the communities we're targeting. But you're right, we're going to continue. This is a start, and to continue to build on it. Director Harrington, did you have a question? You're muted, Director Harrington. I'm sorry.
I don't have a question as much. I just wanted to make a comment. And having been, and this was some time ago, a college student myself, who actually put himself through college, any amount of money that didn't come out of my pocket was very welcome. And I think that in the grand scheme of things, it may not be a lot of money, but any amount of money that doesn't have to come out of the student's pocket or their family's pocket, I'm sure is greatly appreciated moving forward. And I applaud you for doing it. And hopefully, as things go forward, we can take a look at this and maybe have something more than anecdotal comments that make us feel that this is really significant.
We will work very closely. I know that Val and her team are going to look to make sure that we monitor that financial need gap. That's really what we're trying to close, and where we can be very impactful is what is the gap between the student contribution, family contribution that this could help cover, and books, which I know that when we actually talk to some of the students, and books sometimes don't get equated, and they're kind of pricey. Even they're not maybe hard books anymore, they're electronic, but they can be really expensive and can really be a big difference in how you perform academically. So trying to find those things that sometimes are invisible costs, closing them so that the students feel fully supported and know they can walk into the program confident that they can complete it and then finish it without a large legacy of debt. And so we'll continue to monitor that and bring information to the board on the impacts that it could have. And 10 are the starting. We do have at the medical school portion, those go up to 20, and that's very considerable in what you're helping to do.
Director Curry, it looks like we have a question. You're muted.
You're muted.
Okay.
Yeah, I'd just like to add, it's a comment. As a parent who currently has a student in school now, I think the science, one of the components of the science is in fact the gap that we should be focused on. That could be the barrier to make all the difference in the world for a person going or not. And so if you were to up these amounts, you're talking about a greater number of individuals who may not even have that opportunity then to get in, because that gap could be 10, 20, 25,000. So I think this is initially the way to go, and you just keep our eyes on it and monitor it. I think in success is important as well. But for me personally, I think it's the quantity of students that we can get in and not miss this opportunity. And that, again, small amounts can make all the difference of what's left for the student contribution. Thank you.
Thank you, Director Curry. Directors, any further questions? Again, Mr. Rocha, thank you very much for a thorough report, Dr. Wellville and Dr. Hasbrook as well. We really appreciate it. No further questions or comments from the board will now be going into closed session. Action is not anticipated to be taken in open session after the closed meeting has adjourned. I'd like to entertain a motion to go into a closed session pursuant to the following exceptions to the Open Meetings Act: 5 ILCS 122C 1, 2, 11, 12, 17, and 29. We have a motion.
So moved.
Second.
Second.
Thank you. The motion has been made and seconded. Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to go into closed session. Aye or nay, Director Curry?
Aye.
Vice Chair Deere?
Aye.
Director Garza? Director Garza? Is absent. Director Guggenheim?
Aye.
Director Harrington?
Aye.
Director Kim? Is absent. Director Keding?
Aye.
Director Munar?
Aye.
Director Prendergast?
Aye.
Director Ryder? Director Ryder? Is absent. Director Story?
Aye.
And Chair Taylor?
Aye.
You have 9 yeas and 3 absent.
Thank you. The ayes have it. Motion carries. Directors, I'll see you in the closed session.